Good morning, afternoon, everyone. I have recorded my presentation that I was due to give last week for those that couldn't come due to the social distancing that we're having to employ due to the coronavirus. And it's very apt at this time to be giving this presentation in a remote format, because this is how online therapy works and gives a kind of understanding of what is entailed and how it feels to have online therapy and remote working, that so many of us are having to turn to using at this time. So my name is Clemency Jacques. I am a counselling psychologist. I currently work at the Marguerite Centre for Complex Substance Misuse Services, but I also specialise in online therapy, and in various other roles. I work for services where we deliver NHS online IAPT therapy, and I'm also currently on the working group for the Division of Counselling Psychology for the BPS, the Digital Technology Healthcare Group. And we're liaising with the Counselling Psychology Division, who are developing guidelines and competencies for online working. So I started becoming someone who specialises in online therapy because I myself struggled with health problems, and therefore wanted to explore how I could continue working and continue having a career and continue working really dynamically with clients, but from home, just in case I needed to do it. I've done a lot of training. I did my general certificate in online therapy. I also trained in virtual reality therapy, which was really interesting. And I'm currently doing my diploma in online supervision. And I thought it was important to do the training because, much like someone who does one-to-one therapy going into working with group therapy, one does need a little bit of training, because there are slightly different nuances in the styles of working and risk considerations to think of. So it is important that I didn't just go from my face-to-face working to working online without having some specialist training and benefiting from the experience of all of the trainers that I've benefited from, who have been using remote therapy for decades. And as my work for part of a company called Dr. Julian, where we've been delivering a lot of IAPT contracts for the NHS, I've been involved in a lot of behind the scenes service development of how one can meet the NHS guidelines and the necessary requirements for information governance, for risk management, but doing that online. So it's been a really interesting process for me, and I'm hoping to sort of pass on some of that knowledge to my NHS colleagues as we work towards thinking about delivering remote therapy or remote working for nurses and care coordinators. So what do we mean by online therapy? There's actually a lot of things entailed in it. There's the obvious one, video, then the second most obvious is voice. We also work quite a lot with email and live chat or SMS therapy, which has been a really interesting eye-opening experience for me that I will talk about later. There's also a lot of sort of automated programs, also known as guided self-help. So I'll talk a bit about that. One area that I'm really excited about is apps and the use of those for online therapy. I talk a little bit about the virtual reality therapy, just because that's an area that I specialize in, and then also talk a little bit about the blended approaches, how you can mix therapy in face-to-face with remote working or video therapy and email therapy or guided self-help and an app and some voice therapy. So we'll talk about video first. It is the most common digital intervention. And I think that a lot of therapists, psychologists, other people working in healthcare feel more comfortable with that because it most resembles the face-to-face working. You get to see the person, you get to see their visual cues, you get to see, hear their tone, you get to see them smiling, nodding. And it's best done through a secure platform or video conferencing. But it's really important to make sure that the format that you use is GDPR compliant. A general Skype account is not considered to be suitable or secure enough most of the time. Skype for Business is okay. Also, some people talk about using FaceTime or WhatsApp, and those are a bit iffy for using for privacy reasons, mostly because FaceTime requires being linked up to an iCloud account, and most often that's someone's personal iCloud account, and WhatsApp for the same reason. Although I have been told this week you can set up FaceTime and WhatsApp using just an email, so I'm going to look into how one can do that. And the ones that I use are Zoom, that's what I'm recording this presentation on, and VC is another one, and there's all sorts of other ones. I think Microsoft Office has Microsoft Team. There's another one I heard about today called Fuse. So there's lots of different ways of working. They all pretty much do the same thing. There's lots of different functionalities. The most important thing when doing this is that it's done with a private space at both ends. So making sure that if you are having a video session with a client, that at the other end there isn't someone else in the room, and at my end making sure that no one else walks into the room, or if you're doing it from the office, make sure that you're in a private room, there aren't any other work colleagues around. So there are lots of pros of using video. It allows you to see the clients in their own environment. And I find that really interesting because you can actually see what it's like for the clients at home. You get to see a little bit of what their home environment is like, which you don't do when they come to you. And that can actually be a really useful guiding piece of information for what their day-to-day experience is like, especially in this time of self-isolation. It's a really flexible way of working. It allows for greater choice for clients because they can do it at different times. We aren't bound by the hours where services are open. There's a lot of clients that might be working 9 to 5 and therefore can't get to sessions, but can prefer to do them in the evenings, for example. Another thing I really like about it is that you can see the faces much closer. Right now on the screen, I have my screen quite close to my face, and so the person at the other end, if I was on big screen, could see much more detail in my expression, and that allows for a slightly different non-verbal cues, a more nuanced expression, so you can pick up on those really subtle cues a little bit better than if they were sat across the other side of a room from me. And clients can feel more comfortable working online because they don't have to go out to a service, which is good for people who are struggling at the early stages of a social phobia, for people that might be transitioning gender, and other reasons that clients get anxious leaving their house, coming and sitting in a waiting room, coming to a service. It's also really convenient. It's good for those that are in work. It's good for people with small children who are carers, who can't get out of the house as much. It cuts down on the costs of traveling, for example, the time of traveling, so that rather than having to spend 45 minutes traveling to appointment, an hour for an appointment and 45 minutes traveling home, they really have, a fraction of the time that they would have had to have done, which also makes clients more likely to really want to engage in the process because it's easier for them. And it's also good for those who have disabilities, such as myself. I really struggle with traveling because of a back problem. And so being able to do it at home just it opens up doors for clients that otherwise might not have been able to come to therapy as easily. It's also greener. It reduces the impact on the environment, which is something that we really need to think about in this day and age. And I know that Camden and Islington, as an NHS trust, are thinking about ways that they can have a more green approach. And it can be used in full sessions or for quick catch-ups. You can set up links between you and your client that you use all the time, and you can send them a message saying, do you want to have a quick 5-10 minute chat? And you can see them via the video. It has that sort of convenience factor. There are some cons of using a video. You can't see their whole body physically like you can face to face. You can't see if they're fidgeting, if their feet are tapping, if they're clenching their fists. So you do have to rely on different non-verbal cues, and that is it's something that experience really helps with, but also the training really helped me with learning to pick up on those slightly different, more nuanced ways of working. It really relies on a good internet connection at both ends, so that you need to have some Wi-Fi testing. There's a website called Speed Test where you can check the quality of your Wi-Fi connection, and that also relies on our clients having a good internet connection, which can be a problem for a lot of them. It also requires them to have the ability to use a video. A lot of our clients might not have smartphones, might not have Wi-Fi, might be relying on other formats. So that does limit the amount of people who can use it. However, as opposed to 5-10 years ago, when most people didn't have good Wi-Fi or smartphones, nowadays the majority of people have those two things. So that's really opened up the world. And what that means actually is that you can use the remote working for those that have smartphones or laptops and good internet connection, and save the resources for those that don't, that need to be seen face to face. There's a lot of cons of video. People say that there's no physical contact, you can't sit in a room with the client. But then as professional clinicians and practitioners, we need to be physically boundaried anyway. So I often haven't found in my online work, especially with people who are very traumatized, that I have missed out from not being able to physically be in the room with them, because there's other ways that I can offer reassurance. Another con of using video is it does require a good level of computer literacy. I tried to get my mother, for example, to use a Zoom, and unfortunately she just couldn't get it to work. So for someone like her, who gets very confused using the computers and websites, it wouldn't be suitable. And you do need to have backup options. You need to contingency plan for online working. If the Wi-Fi drops out, if the technology fails, if the phone gets broken, you do need to have backup options. You also need to think about how you can record notes and things like that, which if you were in service, you can do quite easily, but from home you need to think about, right, what's the contingency for that? And so often a lot of clinicians who work online primarily will have dongles or some other second line that they use for emergencies. And I think another con of the video that I've experienced in my working, particularly in a case with domestic abuse, was that I couldn't guarantee privacy at their end. I was working with a client once, and it turned out that actually they had a husband who was listening in from their end, and that is a problem. And so we in cases such as that, for example, it might not be a good way of working, or they might need to think about how they can guarantee privacy at their end. Can they go into a car, for example? Is there somewhere else that they can use? And so that also needs to be thought about. So there are some common concerns. What about the quality of the therapeutic alliance? Can you still develop the same warmth and therapeutic bond that you have with your clients online as you can in face-to-face? I think with video, there are a lot of face-to-face skills which can be easily transferred to this format. But I think that's also why it's really important to have the training, so that you can have some case studies, you can practice in advance, and you can do that under the supervision of people who are very experienced at doing this, and you learn the knowledge around it. It's also interesting because there was a psychologist called Sula who noticed something called the disinhibition effect, where actually there are a certain subsect of clients who felt more able to be disinhibited on the online format, whereas they might have been more reserved face to face. And that was a really interesting finding, and has been replicated a lot of times, that with certain people, they can be more honest with me using the video or voice or SMS therapy than they ever would face to face, where they would find it too overwhelming to disclose experiences of trauma, for example. I have one client who, we were doing the online therapy, didn't want to look me in the face when they were telling me some historical trauma, and so they felt that they could turn off the video and just tell me by audio. So that was a really interesting sort of effect that has that sort of sidesteps some of the concerns that people might have about the quality of the therapeutic alliance. But again, it's all about the quality of the intervention and therapist skills. Another concern is, where would I do this? If I was to do remote therapy at work, what could I use? If I was in the office, for example, I still have the same problems with making sure that there's a room available for me. And so one of the things that some people have started doing is sort of having pods, dividing up office spaces into smaller spaces, where you can just be with you and the client on a video using headphones. It's not ideal, but some people are working towards converting communal office spaces to more private spaces to enable the use of privacy and remote working. A really big concern is risk. This is something that I've been working a lot in my other work. How do we manage remotely risk? And I think a lot of that is the same as we would do in person, making sure that we have details about the clients that we need, their GPs, their home address, making sure that we have access to our colleagues if we need to discuss risk, making sure that we keep really good notes. So that does have to be thought about before switching to remote working or online therapy. Another one to think about is jurisdiction. If that mostly comes up when working internationally in other countries. For example, I can work in most countries online with my clients in the other country. It then comes under their jurisdiction, apart from America, where my insurance doesn't cover it and it doesn't cover my qualifications. Much like if I was to go to another country, can I set up practice there using my existing qualifications? And I think you can in most countries, but I know that somewhere like America, for example, and I think there are other places where you couldn't just do that. So you do have to think a little bit about jurisdiction. I think that also applies to boroughs, NHS trusts, where those clients might be. And it's also really important to think about supervision, making sure that you have got supervision booked in so that you're not doing a lot of completely lone working, that you're still engaging in discussing clients with your colleagues, that you're still making sure that you have good supervision. Some people miss being in the office, being able to just grab someone for 5 minutes. So sometimes it's good if there are sort of drop-in slots for someone in senior management. We have an on-call duty system where in my online work, where there's someone available if someone needs to just bash some ideas off against someone or talk about risk or something like that. So the next style of remote working that I want to talk about is voice. So audio conferencing or phone, or something called VoIP, video over the internet protocols, where you can hear the client but you can't see them. And quite a lot of clients prefer this option. It's certainly much easier for colleagues that are sort of working in the services that might not feel as comfortable with technology, because you could just pick up a phone and talk to them. I guess we have to think about why some clients prefer this option. Are they being a little bit avoidant? They don't want to look you in the eye, or is it because they're better able to concentrate just through the audio? And it does offer more flexibility for clients in the end. They don't have to worry so much about being in a suitable environment for a video call, or about, sitting upright and being suitably dressed, that you can do it over the phone. And then so for people who are severely depressed, that requires less of them and makes them feel more able perhaps to engage in a session. Again, it offers more flexibility and it doesn't require interconnection, but it does require things like phone signal and landlines, something which more and more commonly people don't have at home. It requires less bandwidth. So if you do have an internet connection, if you're using the audio conferencing and the connection isn't great, if you turn your video off and just use voice, often that reduces the problems of there being sort of glitches or delays. And you can still portray a lot of warmth and therapeutic alliance over the phone. As we all know, when we have conversations with friends or family members, you can still get a really good connection using just audio. But it does mean that you can't pick up on any non-verbal cues. So more verbal cues do need to be explicitly used. So being able to use or other phrases that convey that you're still listening, even if they can't hear you. Email is another form of therapy, and this is most commonly done by using the therapeutic hour to write each other thoughts, reflections, experiences and questions. Often my clients will write me an hour's worth of an email, what they want to talk about, and then I will spend that hour to read their email and to reflect and comment and interpret and support them via the written format. Now, this is what we call an asynchronous therapy method, where you don't have to be available at the same time as each other, which again increases flexibility, but it also means that you can sort of go away and read the email and think about it and then come back to it. It also means that our clients can do the same. They don't have to do a whole hour's worth. They can spend 10 minutes here, 10 minutes there, whatever feels sort of manageable for them. And that hour can also be split up, so they can spend half an hour writing their email, then I read it and respond, then they can spend another half an hour. So you don't have to do that whole hour's chunk there. They can have that back and forth. Again, one has to think about why a client is using this method. Is that avoidance? Or is it because they work in a business and they can't find an hour, but they can find a certain amount of time to do it? Or if they have children, or if they're only free late at night, for example, where it's not possible to have a therapy session, they can still access some kind of therapeutic help, or get clinical contact with someone in some form. Again, this requires a different type of therapeutic alliance. One has to be really good at writing and conveying warmth and concepts through the written format. And I think one of the benefits of this is that as someone I had to have do some email therapy sessions for myself as part of my training to know what the experience was like. Just the time that's spent writing can be really reflective experience in itself, that whilst writing things down, it made me think about things that I wouldn't have normally thought about. And another really good benefit of emails is that it can be read back after sessions, that I can go back over what has been said and really mull it over and think about it. And so that you can look back over emails that have been sent, for however long you've done it. You can check back into that therapy session 6 months ago and see that process and that progress, which you can't do in a video or voice unless you've recorded the sessions. And obviously, if you record sessions, that brings up problems around data protection as well. And so emails have to be, when you think about it, they have to be done in a secure format, using a secure email address, or through writing things in a Word document and then password protecting those documents, sending them by email, and then sending the password in a separate email, just to make sure that those are sent through a secure line. So another really interesting and new way of working is sort of live chat, SMS messaging. So this is what we call synchronous, so you're available at the same time. It's actually proving to be really popular among young people. In the service that I work at, we are finding that sort of particularly young men and women, those who are at college, much prefer this format. Probably because a lot of the communication that they're doing nowadays is live chat. They are very familiar with this way of communicating with other people now. It's good because it requires less privacy. So someone can be sat there on their phone in a coffee shop doing a therapy session and no one else would know. It's not great, but if that's the way that the client wants to work and that's what they feel comfortable with, that's what they can do. It is a different style of working completely. So you have to use short to the point sentences, shorthand, perhaps some people are even using things like emojis to convey that they are listening, or that they're smiling, or that they're being warm. If someone is writing a long sentence, for example, they can use, type ... to signal that they are about to write quite a lengthy sentence and they are listening, they are typing. It's perhaps not best suited to complex presentations where there's a lot of information that needs to be got through in that time. But it can be quite good for formats like CBT, for example. And it allows for more creative ways of working. You can send links to resources, you can send photos or diagrams of things. And some people find that a really interesting way of working, and certainly the clients find that a very interesting way of working, and that it's opening up a different dynamic to the traditional face-to-face 50-minute old style of working. You have to choose the right program for doing this, and different programs offer different functions. Some functions require can mean that you can dictate, so that obviously makes it much easier if needs be, but of course that introduces things like spelling errors or dictation errors, and I know that, for example, in WhatsApp, although I wouldn't use this myself, I do find it quite helpful being able to you click on it and you can click reply and it can show the exact sentence that you're responding to. And I think there's other programs where you can do that. Again, same as email, this can be read back later for reflective purposes. So someone can go back over what they've said or what their therapist has said, or what their key worker or care coordinator has said. And a lot of communication happens via text these days. So more and more people are becoming comfortable with it. It's less out there than it would have been 5-10 years ago. I've been doing some live chat supervision recently for my diploma, and that has been a very interesting way of working, and really quite dynamic and very quick and actually quite energizing. But does this again encourage avoidance of social contact? If we have clients who have a social phobia, shouldn't we be trying to challenge them to come out of that and to be more present with the therapist? So some clients do benefit from moving through a live chat and moving towards video therapy in a managed way as part of the treatment plan. So they start off in live chat, they move perhaps to email or voice, then perhaps they move to a video, which can help move them out rather than just requiring someone to come straight out of their house and being in face-to-face contact with people. Guided self-help is another way that people are working and that a lot of NHS trusts are choosing to employ. There are some programs which provide CBT through a guided self-help format. One of the most common, the one that I'm familiar with, is Silvercloud. Here clients can watch videos, read psychoeducation, complete mood diaries and thought records, etc. And these often introduce this sort of artificial intelligence, AI, into working, into reading their responses and using a computer generated algorithm come up with responses to those. There are modules which people can use which are geared towards specific presenting problems. So you can sign your client up for a generalized anxiety or a phobia module, for example. Or if they have 2 presenting problems, you can sign them up for 2 and they can work at them at different times. Obviously, there'll be some input from a therapist at the other end, but less intense than it would have been in a therapist-driven therapy. So they can read entries, track progress, call clients to talk through the content, but this won't be every week. So it is a lot labor-intensive from our end, which can be very attractive for the NHS if they have a client who is presenting for the first time for therapy, that they don't know any of the techniques. So it can be a really sort of good entry point into therapy. And I know that a lot of services are choosing to have their clients complete a Silvercloud module and then start therapy, because it primes them for the therapy, because they have learned some of the concepts, they've learned some of the psychoeducation, they've watched some videos, they know what it's like to complete mood diaries, they've tried some of the more basic behavioral activation, so that by the time they come to therapy, they've already done some of the entry level CBT work. And this is also good. Clients can do it at their own pace. They can pick up these modules in their own time. However, it does take away somewhat from knowing that there's someone else, a real person at the other end there for you. So it does take away somewhat from the therapeutic benefit of the alliance. It also doesn't really allow that much for problems which might be interlinked or interwoven. And it doesn't allow for a personalized approach based on that client's personality. And often it has less take up and more dropout than other types of therapy, because of those factors. The next one, let me just move my video box there so that you can see the title, apps. This is an area that I've been thinking a lot about recently. There's loads of apps already available, especially free apps, Headspace, and Calm, which are mindfulness apps, and they often also have paid for options. There's mood apps where you can track your mood, fitness apps, diet trackers. You can put in how many steps you've done, what you've eaten. I think it'd be really interesting if we had apps that actually integrated all of those into one, so you can see perhaps how your food and your activity tracks along with your mood. There are lots of apps that provide therapy, which make it more accessible on the phones and tablets. These can be accessible if you have an app and you develop an app, which I think is a really interesting concept to do, especially for the NHS. Those need to be accessible from different operating systems. So you can have Apple, Android, Google. And apps are often very intuitive and easy to work. So they are user-friendly, press and it takes you to the point that you want to go to. And also a lot of these apps can be linked to each other. So you could have a Fitbit attached to your app, or MyFitnessPal attached to the app that you develop. It takes a bit of time to do that. And it takes, a professional computer programmer. But I think that's also a really interesting way that you can have apps that interact with each other and can measure things, linking up with your GP, for example, and you can go in there and have your blood pressure read or your pulse read or do your blood tests, and those could all link in together. Book appointments or track your appointments. I know that GPs are already starting to do that. So it's a great tool that can be designed for each service relatively easily. So each service could develop their own app, which it means that it can design it based on its particular service's needs. You can have inbuilt options such as diaries that you can keep and that you can choose to have your key worker read, or just keep for yourself, messaging with your key worker through a secure portal, links to resources, so you can have crisis resources on there, or other carer resources, links to services in your local community, and also things like specific symptom trackers. So for example, if someone has psychosis, they can track their voice hearing or any of their hallucinations or their paranoia. They can rate it. They can put a bit more information in there, which they can look back and read, but also key workers or care coordinators could track. And that might give an indication as to if a client is improving or if they're going downhill in a better way than you can in a weekly or weekly or monthly face-to-face contact. Because often when you track symptoms in the moment, they are more accurate than your memories of what your symptoms were like. And it also can store data, which can be really useful for looking at historical well-being and predicting future well-being. So really the options in apps is endless. But again, a lot of people don't like apps. A lot of people don't have smartphones. And so it's really important that if there is something like an app or any of these other therapy options, that there is a choice, that it is an option, not a dictation. One style of working that I've been doing, and I'm putting into this presentation just because I find it really interesting, is virtual reality and avatar therapy. There's another really creative way of working. A lot of people play computer games, for example, and in some ways, virtual reality and avatar therapy is quite similar to a computer game. And some people really, prefer this way of working because it taps into a different part of their brain, or it's just a bit more interesting than the face-to-face conversations, and it allows for those client nuances that they might have. So there's been and actually the virtual reality and avatar therapy there's been a lot of research recently on that, and it can be used for a lot of different presenting problems in varying ways. So some of these programs, the one that I'm trained in is called ProReal, which consists of representations of particular landscapes or worlds. You can represent people in there using an avatar. You can put objects in there into these worlds and these people, so you can create internal and external situations or representations and use those in a therapeutic way, talking through them with the client. And you can use that in person or via something like Zoom or video conferencing, where you have the audio and turn off the video. So you can actually use a lot of metaphor and imagery with a skilled therapist to explore, for example, using objects such as an elephant, which can represent the elephant in the room, what's not being said, a ticking clock, a bomb. These are all sort of very metaphorical imageries that some clients find more helpful because it's less abstract than using these language and terms in a discussion. When you represent them in a visual format, they take on new meaning, and they can go a bit deeper for some people. And it can be applied to all sorts of theoretical approaches, CBT, DBT, psychodynamics, just Gestalt, schema. And some people can get really immersed in this way of working. I know that ProReal has been used a lot in South London and Maudsley for delivering mentalisation-based therapy groups for EUPD, because you can use the program to represent situations that clients have encountered, and using the program, see them from an outside or a different second, third person perspectives. The Professor Leff from the King's College is doing some exciting research using avatars to represent auditory hallucinations and allowing clients to engage in a dialogue with those hallucinations, which is guided by a therapist, which helps give them a sense of having more control with those over those hallucinations. And that's actually shown some really good results. And so if anyone's interested in that, I recommend they sort of look it up. There's another program called Oxford VR, which is doing a lot of work with phobias, using virtual reality to overcome fear of heights, agoraphobia, spiders, that sort of thing. So why digital health overall? Why should the NHS and Camden and Islington think about putting more into digital health? The number one is choice. It offers choice to our clients, and I think that is really important for the future. It's greener. It reflects the changing times that more and more of us and in the future our children will be working more digitally. It offers different ways of working that suits the client, their particular presentation. So it might, something like virtual reality works quite well with people with autism because they don't have to have as much abstract working. They can, be more concrete. And it's good because it means both staff and clients can travel less home visits. Clients don't have to come as far into the services that are far away from them. It's really good because it can be blended with face-to-face therapy. So you don't have to just do it always online or always by phone. You can, pick and mix in a way which is evidence-based and well thought through. But some clients find that really helpful, especially if they are ill or have to go to another part of the country. It doesn't mean that their therapy has to take a break that week. And it means, you know, staff can work from home. So if there are reasonable adjustments that have to occur, they're more easily met by the service that they work for. And it's better if there's a virus going around. You know, it stops the problem of self-isolation and remote working. You know, with the coronavirus going around, and if in the future, if there are any more viruses going around, or any more sort of health problems, it means that people feel less alone. They can actually keep going, you know, doing more work. The service is getting, you know, more out of their employees, but at the same time, enabling them to be, you know, stay away from work if they need to protect their health. So if we were doing this in person, I was going to ask for us to do a brainstorming session, you know, thinking about how you could adopt any of these digital health options into your service. What do you think could easily be done, and what do you think is like something that you would like for the future, you know, pie in the sky thinking? Unfortunately, we can't, you know, do that because I'm sat here on my own, but you know, my email is at the beginning of the presentation, clemency.jakes@candy.nhs.uk. And if you wanted to contact me and sort of have an interesting discussion or set up an email chain around that, again, that's the joys of remote working. I've talked a lot about apps because I think that's a way that could be really interestingly integrated into our existing services, but there's other ways as well. So thank you so much for taking part in my masterclass, as it were, or at least listening to me talk for a while. And I think that this is something that has a lot of potential, and I hope that you guys agree too. Thank you very much.